So welcome everyone. This is the fourth annual Neonatal Kidney Collaborative Virtual Education Symposium. Today's topic is an exciting one. It is on fetal interventions for congenital anomalies of the kidney and urinary tract through a multidisciplinary lens. My name is Tara Beck. I am a PGY7 nephrology fellow as well as neonatology fellow at the University of Pittsburgh Medical Center. I'm really excited to be co-hosting today's symposium alongside my colleague, Dr. Aya El-Maghrabi, who's a pediatric nephrologist at the University of Virginia. For those of you who are joining us today, not already familiar with the NKC, it's a not-for-profit organization with over 400 members from more than 200 institutions, both nationally and internationally. Our mission is to improve the health of newborns with or at risk for kidney disease through a multidisciplinary collaborative of research, advocacy, and education, which we'll be highlighting today. The symposium is organized by the NKC Education Committee, whom we'd like to thank for their dedication and certainly contributions for putting this together today. We certainly hope anybody who's not already a member of the NKC will consider joining today. So today's symposium is going to focus on fetal interventions for congenital anomalies of the kidney and urinary tract, as I mentioned, through a multidisciplinary lens. We're excited to have over 150 registrants sign in to view today's symposium. And the symposium will be available as a recording for those of you who want to review it or for those who may have missed. So our objectives for the symposium, describe any available prenatal interventions for CACT or congenital anomalies of the kidney and urinary tract, review postnatal CACT management strategies, taking into consideration both the neonatology and the nephrology perspective. And of course, I think the important piece is discuss the ethical considerations of prenatal interventions, weighing the risks and benefits of each. We certainly want to give credit to our wonderful speakers today, Dr. Yar Blumenfeld, Dr. Stephanie Riddle, Dr. Meredith Atkinson, and Dr. Erin Whiteman for their participation today, as well as our 6-2 crew interns, Melissa Zhao and Serena Vigetsi, who are going to be introducing each of our speakers throughout the program. So in terms of the format for today, it's going to be recorded as mentioned for later viewing with the exception of the ethical piece and discussion, just because of the sensitive nature of that discussion. There's going to be a Q&A that will be answered and addressed at the end, so certainly invite you guys to make comments in the chat throughout the presentation. So we'll get the ball rolling. We're going to begin with a case-based approach for this seminar. So we have a 27-year-old G1P0 woman with no significant past medical history who undergoes an anatomy scan at 20 weeks of gestation. The fetus demonstrates bilaterally enlarged, diffusely echogenic kidneys with loss of corticomedullary differentiation concerning for autosomal recessive polycystic kidney disease, or ARPKD. The amniotic fluid index at that time was 8 centimeters, with normal ranging from 8 to 24 centimeters. So a follow-up ultrasound done several weeks later at 22 weeks is notable for a drop in AFI to 4 centimeters. The OB recently learned of prenatal interventions being offered at some institutions for prenatal renal disease and refers this patient to an MFM specialist, Dr. Blumenfeld, for multidisciplinary consultation at such a center. So now I'm going to allow Melissa Zhao to introduce Dr. Blumenfeld. She is a pediatric nephrology fellow at Stanford.
Yes, perfect. I have the pleasure of introducing Dr. Blumenfeld. He is a professor of maternal fetal medicine and obstetrics at Stanford University School of Medicine, and he'll be discussing prenatal interventions for CACT.
Thank you, and let me start sharing my slides just in the interest of time. I want to thank the organizers of this meeting for the invitation and allowing me to present this. This is a talk which usually I conduct over the course of about an hour. So there's a lot to cover, and I'll try to run through a few topics. This is a topic that is near and dear to my heart, and again, really appreciate the opportunity. I think for the case report is really just a launch pad, and then I'm happy to answer questions about that specific case. Full disclosure, I'm an inventor and co-founder in a company that developed a novel fetal vesicoamniotic shunt, so I do want to disclose this, but given the rarity of in utero shunting, I don't expect to make a lot of money off of this. unfortunately, but this is my disclosures here. I do want to discuss two topics that are really quite contemporary in the treatment of these diseases. One, of course, is serial amnioinfusion for early onset renal failure, and I wanted to recognize Meredith Atkinson, who will be talking about a different topic, but she's really kind of leading a lot of endeavors in this area. And the other one, of course, related to the shunt that I just described and the limitations of treating fetal lower urinary tract obstruction. I don't have to tell this group, kidneys develop very early on, even before many women realize they're pregnant. They're quite common as a group, but when we're talking about early fetal renal failure, the ones with early onset oligo or anhydramnios, it's really quite rare. But thank you for the referral as well. In this particular case, we do get referrals in these kinds of cases. So we can see the kidneys very early on in gestation. I'll show you a couple of images even from the first trimester. But in terms of early onset renal failure, we're talking about a variety of diseases, including cystic renal disease, obstructive uropathies, ludo cases, medications, and of course, bilateral renal agenesis. Ironically, a lot of times people think, like this ARPKD case that was just presented, that these kidneys are bright and whatever. And even when we think it's ARPKD, oftentimes it's not. So this is ARPKD is even quite rare among a group of very rare diseases. Again, I don't need to tell this group that the biggest problem with early onset renal failure is not the kidney, because people like Dr. Atkinson and others have developed really amazing ways of performing dialysis now, not only in neonates, but in premature neonates that have growth restriction as well. But it's really about the lungs. And lung development starts very early in pregnancy. And if you have very low or no fluid, that really inhibits lung growth, and these babies are just born and can't breathe. So when they turn from water mammals to air mammals, they just can't make that transition. And this is really the biggest issue. And so the question, of course, is there a role for fetal therapy in these cases? Who's the natural candidate? Can we change the natural course of the disease? For what conditions? And how do we think about both the fetus and, more importantly, the mother, right? Like, so it's not just about fetal medicine, but it's really about maternal fetal medicine, and who are appropriate candidates. So a lot of you have probably heard about amnioinfusions as a treatment for these severe cases, but amnioinfusion is not a novel therapy. This is a case report from 1994. This is in the Green Journal, which is our leading journal, describing a case report where they injected fluid into bilateral renal agenesis. So you have to understand, for people that deal with fetal therapy, you have an ultrasound, you have a needle. It's quite simple to start thinking about putting it into the uterine cavity. And lo and behold, in this case, the child survived, certainly beyond the first 24 hours. But that's a brain on the right-hand side, for those of you guys who haven't seen a brain in a while, which tells you, of course, the child ultimately did not survive. And in this particular case report, the child actually ended up having adverse neurological injury, and put a pin in that because it'll come back to haunt us a couple of decades later. And so the conclusion of this case report was, at present, this type of procedure is not an appropriate intervention and would be strongly discouraged. And it was very strongly discouraged for about 20 years, until a group from Johns Hopkins decided to try this again. Same thing, bilateral renal agenesis, the most severe form of early onset. It's not even renal failure, it's renal agenesis, and obviously associated with very early onset anhydramnios, which means no fluid. So when you have, like the case that was just presented, you can see oligohydramnios at like 20 to 24 weeks. When you have bilateral renal agenesis, you're talking about anhydramnios, no fluid, by like 18 to 20 weeks. And they said, let's do this. Let's do serial amnioinfusions. Let's try to help this particular fetus. And lo and behold, the child survived, certainly in the first 2 weeks. And then it ended up being a child of a prominent congresswoman. And this congresswoman from Washington State then went on to a lot of lay press. You can see this is not the JAMA, this is People magazine, and started advertising her miracle baby. And then we're not really sure, but certainly in the first couple of years, a lot of people tried this intervention. Now, we don't know how many succeeded because none of it was published. We assume that a lot of them failed. And so Hopkins, or a couple of people started before the Hopkins group, started to think about, okay, is this ethically justified to do? And you can see in this editorial published 3 years after the case report, the bottom line there in bold is serial amnion infusion should not be offered as a treatment, only as approved innovation or research, because nobody really knew how many times it was not successful. And then Sugarman and a group from Hopkins convened a multidisciplinary group, including pediatric nephrologists and others, to assess whether and who should be doing serial amnion infusions. And what they argued for was a multi-center collaborative effort on this, studying the risks and benefits. And this really launched current endeavors. And so amnio infusion as a technique, when we think about fetal therapy, is relatively benign. You know, in our world, we're talking about open fetal surgery, opening the uterus, you know, fixing spina bifidas. Here, it's an ultrasound and a needle that goes and sort of creates the space there, and you can see a little bit of fluid then goes in, and then you see a fair amount of fluid. Now, it's important to remember that these fetuses swallow fluid, and certainly later on gestation, the therapy only works for a few days, and you got to do it again and again and again. So we counsel patients that it's not a one and done, and that we have to do this intervention multiple times during the course of the pregnancy. So as of 2018, there were a lot of questions. There was, what's the optimal time to start? We know that the lungs, you know, lung development happens early on, but when is it too late to do this? What's the optimal frequency? What's the fetal benefit, maternal risks? What centers should be doing this, if anybody at all, and what kind of oversight should there be? And this really launched the RAFT trial, which is housed at Hopkins. It was started by Eric Jalen, who's a pediatric surgeon, and then transitioned to Gina Miller, who's an MFM, and Meredith, who's on this call. And really, the aim of the study was to assess the safety and feasibility and efficacy of serial amnion infusions, to determine the maternal and fetal implications. And even though the outcome of interest is pulmonary, there was a lot of debate back and forth about how do you quantify a pulmonary outcome. And so Eric and his colleagues and others who had input into this said, okay, we don't know how to quantify lung development, but clearly these babies die within a day. So let's assume if a child survives to 14 days with dialysis, the lungs are good enough. And so this survival for 14 days really was sort of a proxy for pulmonary morbidity and mortality. And of course, it ultimately received NIH funding. There were a group of initial centers, and then it got expanded to centers across the country. There were two arms to the trial. One is bilateral renal agenesis. The other one's a fetal renal failure arm, thinking that BRA is a more severe form, whereas fetal renal failure is sort of a catchment group that includes ludo and cystic renal disease, obstructive uropathy. Interestingly, ARPKD was excluded from the fetal renal failure arm because it was felt to be a more severe form and maybe associated with a genetic disease. And so the only exclusion for the fetal renal failure arm is the ARPKD, although we are aware of serial amnion infusions outside of RAFT for ARPKD. And patients could choose to undergo intervention or expectant management, thinking that maybe there would be an argument that with modern technologies, expectant management would result in a live birth. Again, primary outcome there on the left, a lot of secondary outcomes, including survival to transplant, quality of life years. Again, it's an hour talk. I don't have time to go through all of it, but a lot of secondary analyses. Similarly, many inclusion exclusion criteria. You don't have to squint your eyes. I'm not going to go over this. You can see the slides later or read about the RAFT trial. But the point is this: you needed to have anhydramnios or severe oligo by 22 weeks. So remember, we were thinking a lot about this lung development, but then there was this element of feasibility. So we know women undergo anatomy surveys at 20 weeks. And so we wanted to make sure that we're capturing those women. And the first amnio infusion happens or needs to occur before 26 weeks. And you might say, well, maybe we missed the boat, but you'll see that it's actually not the case. But there was a lot of balance between biology and feasibility of this trial. And then typical exclusion criteria, including maternal and obstetric etiologies that we oftentimes have in fetal medicine. And I think one of the more important inclusion criteria that people miss on the left-hand side there is the need for multidisciplinary consultation. You'd be surprised how often serial amnio infusion is done in clinics without appropriate neonatology, nephrology, ethics, and other folks. And so all the RAFT centers really have appropriate multidisciplinary elements in both the consultation and the therapy. So study updates out of October 22nd, 2025. For the BRA arm, the Data Safety Monitoring Board met in 2022 and stopped recruitment after 18 of 35. And they stopped it for two reasons. Remember, the expected outcome is 0% survival. And what the actual numbers were in the achieving the primary outcome, meaning survival to 2 weeks, was actually 77%. So with serial amnioinfusion, we expect nobody to survive to 2 weeks. 14 out of 18 survived. So clearly a benefit. However, the DSMB had concern about what was happening after 14 days. And a lot of deaths happened after that time. And certainly there was neurological morbidity similar to what we saw in that case report that gave the DSMB pause. Recruitment to the fetal renal failure arm stopped in February. Data analysis in that arm is ongoing and a manuscript is in development, and I won't be able to share any of that. However, you can read about the outcomes from the BRA arm. Maybe you're familiar in JAMA 2023. I won't go through this a lot, but I just wanted to highlight the following. This is one of the tables from the manuscript there. You can see survivors on the left, non-survivors on the right. Survivors had more amnio infusions, delivered at later gestational ages, and had higher birth weight. And this is all the outcomes in the live-born infants. And you can see that a lot of them, even though they survived to 2 weeks, a lot of them ended up having death beyond that for a variety of reasons, including infections, hypotension, other things. So it's not an easy road, even when you make it to 2 weeks. And of the ones that survived as of manuscript publication, which was 4 cases, and were on dialysis, you can see a lot of them had stroke, germinal hemorrhage, and then another stroke. So there's a lot of interest now in assessing how we can not only help these children survive beyond 2 weeks, but how we can reduce neurological morbidity. And a lot of that probably has to do with standardizing neonatal management and many, many, many lessons learned on the neonatology and nephrology side over the last couple of years. So how do we translate those findings? Again, we only have the BRA group data that has been presented and peer reviewed. Do we look at the cup half full or half empty? Do you say, oh my God, all these babies had strokes, very few survived? Or do you say, well, they survived, but look, you compare it to prematurity at 23, 24 weeks, where we also have 50-50 survival. Nobody says don't resuscitate those babies. So it really depends on how you view it, recognizing that a lot of these interventions were happening outside of RAFT centers. Do we offer this as an intervention or clinical care? Is it still research? Are 18 patients enough? And should we think about a RAFT 2.0? But how long will that take to launch and get funding for? So an interim solution was really creating this RAFT registry, again, housed at Hopkins with Meredith. And so a lot of centers that participate in the RAFT trial and outside the RAFT trial are now collating their data and submitting it to the RAFT registry. And it sort of became this interim solution. So next steps, we're joining the RAFT registry. We'll get some data there. And there is a RAFT 2.0 in development, looking at standardizing pediatric and nephrology care to try to see how we can optimize the outcomes of these children beyond 2 weeks. This is an example of a RAFT baby. This is from the mom, not from my TikTok. Okay, we'll stop there. In the next 5 minutes, I just want to mention ludotherapy because I can't talk about fetal interventions for renal anomalies without talking about ludo and shunting. Ludo is not a diagnosis. It is a catchment of a variety of different indications that you can see there. People use, oh, it's a posterior urethral valve. You never know with ultrasound. Again, ultrasound is not a subtle finding. Excuse me, ludo is not a subtle finding on ultrasound. These are first trimester images that you can see on the left. That big black circle is abnormal. You do not need to be an ultrasound expert to know that a fetus should not have a basketball in its belly. And you can see the hydronephrosis in the kidneys as well. This is one of the smallest congenital anomalies we have. Think about it, a urethra is not formed or it has stenosis or whatnot, but it's one of the most lethal. The only thing more lethal than severe ludo is acrania. Okay, everything else is less lethal. Hypoplastic left heart is less lethal. Excuse me, BRA is equally lethal. And similarly, again, pulmonary morbidity is the issue. And so this concept of vesicoamniotic shunting is not new. People developed it over 40 years ago. The idea was to bypass the obstruction, help the amniotic fluid go into the amniotic cavity and improve pulmonary morbidity. These are some of the shunts that we have. The one on the left, the Rocket or the Rhotic shunt, is out of Europe, and it's actually on hold because the plastic that it's made from has some issues with it. The Harrison or the Cook shunt is in the US and available. Somatex is in Europe. There's a double basket shunt in Asia. We don't have Somatex. We don't have the double basket in the US. And the biggest problem with these shunts is that they dislodge in up to 50 to 80%. This is what shunting looks like. It's under ultrasound guidance. We have a trocar that goes in. Then the distal end goes into the bladder, and then we have the shunt at the end there. And what you see here is that a very distended bladder becomes very hypertrophic and compressed and actually quite dysfunctional. I know many of you guys realize this. Many MFMs don't realize this, that this dysfunctional bladder not only affects the index kidney, but when these children need kidney transplant, it can affect the subsequent kidney as well. Um, Again, many concerns whenever you do a fetal intervention, concerns to the mother, concerns to the membrane, concerns to the placenta. But the biggest issue is shunt dislodgement and migration. So think about this. You have a patient with this anomaly, you counsel them appropriately, you do the procedure, you take them to the operating room, you do an invasive procedure, and a week later, the shunt is not in the right place. And you got to do it again and again and again. So clearly, we want to improve that. Obviously, a lot of costs related to that dislodgement. So you have NICU stay because of many interventions. And then even in survivors, because of the dislodgement and the imperfect solution, you have chronic renal failure costs there. And so we actually wanted to see what is the cost of this issue. What if we could reduce the dislodgement for 50 to 10%? What kind of benefit would we have? So we created a model. If we could lower dislodgement from 50 to 10%, we used 1,000 theoretical ludo pregnancies. And if we could create a novel shunt in this way, we can have 60 fewer cases of end-stage renal disease and 10 fewer children with neurological deficit, with a potential lifetime saving of $130,000 per case. And so we got together, a bunch of us, a pediatric urologist on the left, bioengineer in the middle, myself, pediatric surgeons on the right. And we started with sort of off-the-shelf components. So the first iteration, you can see at the top there, it's a ASD closure device that we picked together. And we had sort of the North Star elements that we wanted to address on the left there. We wanted to reduce dislodgement. We wanted to make it atraumatic. We wanted to have it kink resistant, and we wanted to have it extend when the fetus grows. And we conducted a lot of benchtop and early animal studies, and you can read more about that on the manuscript on the right in 2022. Our second iteration, you can see it starts to look more like a medical device. We're no longer using off-the-shelf ASD closure devices. We're creating the nitinol ends ourselves, and we can modify it in a certain way. Went back to the benchtop test, proved that the pull-out force is much better than the Harrison, proved that we can kink it and twist it in certain ways. And then we started collaborating with a sheep lab in Leuven, Belgium, which has an animal model for Ludo. And this is the latest iteration of the Vortex shunt. You can see now it really looks like a medical device. You're looking at one piece of nitinol that is laser cut and electropolished and then covered with polyurethane in the middle. So the whole shunt end to end is one piece of nitinol. And we spent a lot of time with the design and elements. And then we have these animal studies. So Ludo, for those of you guys who are not familiar with sheep, a sheep gestation is 140 days. Ludo is created surgically at 75 days by cutting the urethra, and then we deploy the Vortex shunt and we harvest in the end. And so far, we've done about 17 fetuses. We have perfect deployment. We see no dislodgement, and then we're analyzing outcomes afterwards at harvest. And so here's an example of the kidney. So this is a normal kidney. This is the sheep kidney with Ludo, and you can see with our shunt that doesn't dislodge, the cortex looks a lot closer to the controls than it does to the Ludo, and you maintain some of that corticomedullary differentiation. And then our friend Enrico loves these bubble bath studies where he's testing the bladder muscles in response to carbachol. And you can see 3 curves here. You can see a normal response. You can see a suboptimal Ludo response. And you can see that the Ludo shunted response mirrors the bladder muscle to the control animals. So in conclusion, we have no short or long-term dislodgement. We're in the middle of GLP studies, hopefully on the road to first in human trials next year. We have ongoing assessments, not just on growth pathology, but also histology and other things related to this. So I'll stop here. I hope I didn't go too much over. I apologize if I did. And I'm happy to take questions afterwards.
Yeah. Dr. Blumenfeld, thank you so much. And just a reminder to everybody in the chat, I see some great questions there. We're going to save questions for the end, but I think that, the point about moving the needle forward to the postnatal management is really an exciting one. And I think just echoes the sentiment of the NKC and why we're all here. So thank you for that.
Hi, I'm Aya Al-Maghrabi. I'm just gonna continue with that case. Thank you, Dr. Blumenfeld. That was a great talk. So the patient has made it to the 35 weeks, a gestational age, and goes into labor spontaneously. The baby is admitted to the NICU on non-invasive respiratory support. Initial lab includes serum creatinine 2.5 milligram per deciliter, potassium 3.5, phosphorus 5.5, and BUN at 10 milligram per deciliter. So, Dr. Riddle, how do you counsel the family to help prepare them for their child's NICU course? At this point, I'm gonna introduce our Serena Vegetzi, our next 6'2" crew intern, who is a pediatric resident at the University of Padua in Italy.
Good afternoon, everyone. I'm honored to introduce to you Dr. Riddle, who is a neonatologist and associate professor and the neonatal director for the Cincinnati Children's Fetal Care Center. She is gonna discuss with us the postnatal course of these patients from a neonatologist's perspective.
Thank you everyone so much for having me. I'm going to get my slides pulled up here. Are you seeing these in presenter mode or regular? They look okay?
It looks great.
Okay, perfect. Thank you guys so much for inviting me to present today. As you can tell from my title, I'm really interested in the outcomes of babies who've undergone all kinds of fetal interventions. And this is probably one of the hottest topics in fetal therapy, as we eagerly anticipate the results of the RAF trial coming in the next few months. I'm going to talk a little bit about the role of the neonatologist in the care of these babies, especially those with early kidney failure. And I'm really excited to be partnering with Dr. Atkinson to talk about the care of these kiddos. So to start by answering the question that was first posed, which was, how do we counsel these families? And Dr. Blumenfeld really gave a really important, kind of shout out to that as part of the criteria that the RAF centers and many of our centers utilize for helping a family understand the decision making for moving forward with a fetal intervention. Because it is very easy for a mother to say, I will do anything for the life of my fetus or my child. And it takes a lot of information sharing, understanding their situation to really get across this idea that this is not one decision to be made. The idea of starting down the pathway of amnio infusions is just the very tip of the iceberg in terms of understanding the pregnancy care, the newborn care, and ultimately lifetime of care for kidney failure. And so that's not an easy conversation to have in a 1-hour meeting with an overwhelmed family. And so really trying to make this a multidisciplinary counseling session that does not happen one time, but happens over the course of several meetings is really, really critical. And while we really, as a neonatologist, I want to talk about what I'm going to do in the delivery room and how I can hope to get you home from the hospital, I recognize that I am but one small piece of this journey. And so really having the nephrologist, the palliative care team, the social workers, all being a really important part of this conversation has to happen for any family to make any kind of informed decision in this case. And so really that counseling has to start from that initial visit. That will include maternal fetal medicine, neonatology, nephrology, urology, all of these groups to understand really what is the diagnosis? Do we have the diagnosis right? Are they a candidate for these interventions based on the criteria that we've all put forward? And really, what does that decision about a fetal intervention mean? This is a long path that doesn't end at transplant. And so really helping them understand what this decision means, not just for mom, but really the whole social unit for that baby. I don't know, Dr. Atkinson, if you have anything that you want to add on kind of the prenatal counseling piece before I jump too far into this.
I would just say, no, I think that's great. I think it's a critical piece. It sounds like you do a similar thing. I think it's helpful, like you said, a family who's overwhelmed by a devastating fetal diagnosis to try to do as much of it in concert as we can. So when we do our consults, it's me, one of the neonatologists, the social worker, and then our NICU has a wonderful chaplain who's also a palliative care specialist. And so we try to, at least our group meets together. We don't always have a urologist with us, and some of those are separately, but I think that's very helpful just for keeping people on the same page. And then the palliative care specialist NICU chaplain actually puts together kind of a document and sort of follows up with the family and is the point person for things like follow-up questions and a birth plan. And because I think your other point was you can't do all of this in an hour, and some things need to be revisited. But yeah, I agree with everything that you said.
So starting to talk about kind of the neonatal care of these things, is that there's a huge learning curve. So when all of our textbooks were written, these babies were not resuscitated, they did not survive. And so we're really learning day by day, week by week, month by month, year by year. And I think really as the interventions that have been offered, from just shunting to the more invasive and now serial approach to amnio infusion, we understand that learning curve is on both sides of delivery, really understanding the fetal intervention itself, but also the newborn care. And that learning curve is uncovering new physiology, trying to understand the most logical, pathway to, for example, hemodynamics, and really learning from experts on each side of that. And so it really requires a multidisciplinary team who's thinking about the whole picture of the baby. And so for us, we found that standardized guidelines for kind of their pathway to initial hospital discharge has been really helpful, that bridge neonatology, nephrology, transplant, surgery. Thinking about the times of all of these interventions has been really, really helpful. And that's something that we kind of talk to families about early on. How do we get you from an intubated baby in the NICU to a baby who's going home from the hospital, hopefully on peritoneal dialysis? So as a neo, one of the first things I'm thinking about when I meet with a family in fetal is always, what do I need to tell my team to be prepared for in the delivery room? And so this is going to be, even if fetal interventions have gone perfectly, often a critically ill baby. And so it really takes a team approach to preparing for the delivery of that patient. And so we're thinking about, not just respiratory support, we're thinking about what equipment do we have to be ready for. So we know these babies are going to need often some degree of respiratory support. So do you have intubation equipment? We know they're at high risk of pneumothorax. Do you have neothoracentesis equipment available? Do you have chest tube equipment available? Do you want a ventilator in the delivery room or the resuscitation room with you? Is inhaled nitric oxide something that you utilize at your center? Are you ready for IV access? Is that an emergent UVC? Or kind of all of those things that you might need available and easily accessible to you, either in the delivery room or immediately available in the NICU. We think a lot about pulmonary protective strategies. So this is just another model of pulmonary hypoplasia. So thinking about your early rupture of membranes, your CDH patient populations, we utilize a lot of those similar strategies. So things like using the lowest possible mean airway pressure. So if you can use a non-invasive support, shooting for CPAP, using a low volume fast rate on a conventional ventilator, and using those early rescue therapies, ventilation strategies like the oscillator or the jet are something that we're always thinking about early on. And then just to get back to this idea that I'm going to go through each of these kind of topics individually, but they are not an individual piece of the pie. They have to all be kind of thought of in concert. And I kind of think of it as like the yellow brick road. We're trying to get you to the end of the yellow brick road, but all of these things have to function together. And so each center who provides care to a population like this, I really encourage, if you haven't done so thus far, to get a team of really invested folks from NICU, surgery, nephrology, especially, to be thinking about kind of the holistic care of this patient and how you really get to that goal. So first, let's talk about pulmonary management. Dr. Blumenfeld mentioned earlier the difficulty with naming pulmonary hypoplasia when you didn't die, when we don't have pathologic specimens to say you have pulmonary hypoplasia. So we kind of have these, like poor man's definitions of lethal or not lethal. Is that 7 days? Is that 14 days? Whatever it might be. We kind of know it though when we see it. And the reality is that we don't completely know exactly what the right kind of amnio infusion and the right strategy exactly is yet. What's the right fluid to put in? What's the right timing? What's the right route of doing that? We know, though, based on kind of case reports and the data that we have so far, that it probably does work. It grows survivable lungs at the very least. But we still see that there's some degree of pulmonary hypotension present in nearly all of these patients. So across these case series, across kind of institutional experiences, I would say that uniformly between 70 and 90% of patients will still require mechanical ventilation. And depending on the timelines you look at, that's about 10 days. Pulmonary hypoplasia, they do tend to extubate in kind of that week plus mark, and they tend to wean to minimal or no respiratory support over the course of time. But what does that minimal or no respiratory support look like for them long term? I think many of us have had the experience that they still have some ongoing respiratory insufficiency, I will call it, and you might unmask that need for respiratory support with, say, exposure to anesthesia or a viral infection that comes forward, over the subsequent months. And so many of us are getting more aggressive about screening for that respiratory insufficiency with things like SAT studies and sleep studies, and understanding kind of whether chronic oxygen therapy is something that would be beneficial to that baby. In terms of cardiovascular management, I think this is one of the hardest things to manage with many of these patients, certainly those with bilateral renal agenesis. Many of these patients, all of these patients functionally will have a fetal echo. So you can say, I know that you have a 4-chamber heart, that you don't have a cyanotic congenital heart disease, but that early echo to look at function, to look at pulmonary hypoplasia, pulmonary hypertension is still really important. And so understanding the degree of their cardiac dysfunction, for example, we see biventricular hypertrophy quite a bit on a fetal echo. We know that probably there's some degree of blood pressure dysregulation leading to that. But we know that if we see that, that heart is not going to tolerate tachycardia. And so how is that going to make me think of what my first choice vasopressor should be? For a baby that I'm already seeing that even in utero and potentially on that first, functional echo. Pulmonary hypertension, especially when you're seeing a significant degree of lung disease, kind of goes hand in hand. We know this from CDH, we know this from early rupture of membranes. We tend to, at our center, treat fairly aggressively with inhaled nitric oxide, utilizing oxygen, trying to utilize some of those more permissive hypercapnia and lower oxygen targets to avoid barotrauma, volutrauma, all of those things, but also treating that pulmonary hypertension in the normal ways in terms of addressing sedation and blood pressure support. I think the positive thing that we have seen is that this tends to be a relatively short-lived bout of pulmonary hypertension compared to those babies, say, that have CDH, where it's more of a fixed pulmonary hypertension or a more of a chronic problem, or say those babies that have significant lung disease from bronchopulmonary dysplasia that have a risk of pulmonary hypertension long term. That tends to be mitigated by serial amnio infusions in our experience. So talking about hemodynamics, the hemodynamics of these babies is really, really challenging. And I will not sit here today and tell you that we have solved this problem, because we certainly have not. And so just some kind of food for thought on the topic, in addition to utilizing kind of that functional echo to understand really each baby on an individual basis. We think a lot about early use of steroids, so understanding whether they are relatively adrenally insufficient. It has been very beneficial for our population, and then kind of targeting vasopressor support with the knowledge of kind of what their cardiac function and degree of pulmonary hypertension looks like. We tend to utilize epi here as kind of our first vasopressor of choice, if that makes sense for them, if they're not having significant tachycardia. But you can see there's a lot of other choices. Some centers will utilize vasopressin. Some centers will utilize phenylephrine if they have more pulmonary hypertension as kind of their primary issue. We tend to see that they are volume sensitive, probably because we're volume restrictive in those patients. But we do tend to see that early on they can be quite volume sensitive. And there are other emerging therapies like Ang2 agents like Giapreza that some centers, I think Stanford utilizes this agent more commonly, that I think a lot of us are starting to think of because of the whole RAS pathway with these patients. We do tend to see blood pressure swing. So early on, they tend to be hypotensive, especially if we're using modalities like modified aqua or carpe diem, but then they swing towards hypertension later on after that initial kind of period. And so really having kind of a thoughtful control over their blood pressure, especially if we talk about kind of the neurologic morbidities moving forward. And NIRS can be a really helpful adjunct tool to understanding kind of what your best targets for blood pressure management ought to be. No talk about kidney management would be complete without talking about fluids. So just think about every drop of fluid that goes into these babies from very, very early on. Every flush that you give, every lumen that you're utilizing, all of these are really, really important details. I'm a neonatologist. I love minutia, don't get me wrong, but we have to be thinking even more in depth about these patients and every little thing that we're putting in. Utilizing those concentrated dextrose solutions early on. Don't just throw on D10 at a high volume because they're a preemie, but thinking about all of those degrees of, you know, what is their blood pressure? What is their gestational age? What are their insensibles? Are they on respiratory support? Thinking of all of these things. So I can't tell you that, you know, 40 mLs per kilo is exactly the right number for every baby that has congenital kidney failure. It might not be. So thinking kind of about the holistic picture of what you're seeing, but thinking about, you know, that volume targeting very early on is really, really important, because you're going to have to take off every drop of that fluid that you put in. So it is your problem of your own creation to some extent. Nutritionally, good nutrition is the only thing that gets this kid to a kidney transplant, right? So it's the only thing that heals your catheters. It's the only thing that grows a brain, and it is the only thing that gets you to kidney transplant, size, weight, you know, length, all of those requirements. And so really thinking early on about providing good nutrition to these patients in terms of calorie, in terms of protein. We use TPN aggressively and early in this population. And as they move towards enteral feedings, our feeding of choice is maternal breast milk, with the adjuvant things that you need, like additional protein and fortification to get them what they need within their relative fluid goals. Our center here specifically, we place G tubes in all of our patients as part of our standardized care pathway, knowing that they will need long-term medications, nutrition, etc. I will say a little bit about the neurologic piece of things. So Dr. Blumenfeld alluded to this as part of the RAFT findings, and I'll talk about this in a second. but we also have had a similar experience in terms of the neurologic morbidities that come with these patients that have fetal kidney failure. And so we have added to our guidelines over time a really aggressive approach to monitoring for these things, not just acting on a symptomatic basis. So we utilize modified aqua and carpe diem. So for the first kind of week while those patients are on those extracorporeal therapies, we're doing serial head ultrasounds. We're watching their platelets really closely. We're watching their coags really closely. And so monitoring for those insults early on. But we also know that some of those happen later. And so doing a brain MRI for patients, either if they're symptomatic or certainly if we can get it prior to hospital discharge. And there's been a number of reports about what symptomatic presentation for a neurologic injury in these patients looks like. Sometimes it's obvious, things like seizures, focal neurologic exams. Sometimes it's a little more subtle. We've seen this, babies that are just hyper irritable that were not hyper irritable before. Big swings in blood pressure. Maybe they were very hypotensive and now they're very hypertensive. All can be things that you see that should give you a heightened awareness that this baby is at higher risk for a neurologic injury. And so just speaking to the experience from the RAF study that was published, I think the important things to point out from this study is that it was 80% of the patients in this study, but they were not all bilateral renal agenesis. It was all the fetal renal failure patients. And several of them had multiple episodes of stroke. And so this is not just screen early on and you're through the window. There were two kind of defined phenotypes of injury, and it was ones that you would see in a typical NICU population. So these early critically ill babies that have sort of an ischemic picture. So babies that had DIC, placental malperfusion, an event at delivery, pneumothorax, whatever it might be. But then you also had this pattern of late, potentially no clear inciting event that also presented with significant injury. And so just to kind of move quickly, you can kind of see the two types of injury have very different appearance on MRI. And so just to say, we think a lot about the survival and do they get to transplant as being very big and important outcomes for these patients. And I'm not going to minimize that they are important when there was no survival before. But I think we have to think past that. And I applaud the NKC and some of the groups within the research team that are thinking about ways that we can follow the neurodevelopment of these patients that have gone through fetal interventions, because there are a number of ways that we are putting them at risk for adverse neurodevelopmental outcomes. I'll skip through these a little bit quickly in the interest of time, but there is a mounting amount of literature that survival is possible with and without fetal interventions. This is some newer data from the FIS database looking at patients who had early dialysis. Mortality was 24%. I'm not going to, suggest that every patient in this, large data set had a fetal intervention. That's not the case. But you can see that survival is possible in this very high risk population in whom we're doing some pretty risky therapies in. And you can see that data is kind of mounting in these patients that require early dialysis. Survival is becoming, more and more common. There's data out of our center. There's data out of the RAF trial that's coming very soon that suggests some of the predictors of survival. If you have a lower urinary tract obstruction, your survival is more likely than those who have multicystic dysplastic kidneys, and certainly more likely than those who have bilateral renal agenesis. And so to speak to kind of the BRA arm of the RAF trial, we saw survival was possible with fetal interventions. That is, I think, not as much in question anymore. It's really that attrition to hospital discharge. We saw that in our experience with bilateral renal agenesis. This has been published as part of the RAF trial. And so really that survival to discharge home is the needle that I think all of us as neonatologists and nephrologists are really thinking about. How do we modify that? And how do we think about those comorbidities? And so just bringing it back around to this idea that this is an important but very small piece of the puzzle and part of their care pathway. I'll turn it over to Dr. Atkinson to talk about more of that path.
Thank you. I will just say, Stephanie, first of all, thank you for inviting me, because I was so excited to meet Stephanie. I haven't met her or worked with her before, so this was great. I got to meet her last week. I do really appreciate you emphasizing that the pulmonary disease is a spectrum. You know, it's not just a case of normal lungs or lungs that don't work, and that's one of the things that we try to prepare families for as well. And I guess the big thing I say, you know, when we meet with these families for these prenatal consults, you know, they've come to the fetal center really in a place of hope. They're there and they're hopeful, and that is where they are. And so I'm very honest with people. The neonatologist usually goes first, just like we're doing right now. And then I say, look, I'm gonna spend some time talking to you. I'm gonna give you a lot of information. I think that a lot of people hear this as a string of really bad things that could happen. And I'm not saying that to be discouraging, but I try to be really open and say that I consider my job in this situation to give you as accurate a picture as I possibly can give anyone of what it's like to have a baby in the kidney failure, both within the NICU, and then if they survive beyond, and a child that has kidney failure throughout their whole life. So I think those are the, you know, that's where I'm coming from. And those of you who've done these consults, you can see it happen. You know, they start out very hopeful, and then you start talking, and they sort of, you know, their faces change, and then at some point they're in tears. And I don't want to make people cry, but I also, when I see that, I know that they've heard me, because there are, you know, there are a lot of things you have to make them aware of. And I'm under I don't have the misapprehension that they remember everything we say. And we know that based on conversations we have later in the NICU. And so one of the things we're always thinking about is, how can we do this better? How can we convey information so that people remember, and in a way that prepares them and helps them get ready for the decisions they're going to have to make later. I don't know how much you want me to talk about prenatal counseling now. Okay, we'll pause and then I'll go on to my slides.
All right, so thank you, Dr. Atkinson. So next we have Dr. Meredith Atkinson. She's the Associate Professor of Pediatrics in the Division of Pediatric Nephrology at Johns Hopkins. Clinical research focus, as we've heard of right now, for kidney disease progression in children and clinical trials. She was the co-PI, as we've heard, for the NICHD-funded RAFT trial, and maintains an active clinical practice caring for kids with CKD on dialysis and, of course, after kidney transplantation. She also currently serves as the president of the American Society of Pediatric Nephrology. That being said, Dr. Atkinson, take it away. Well, you know what? I think you're muted.
Thanks. I should also say, while I'm bringing my slides up, as you know, Stephanie shared the work that Dawn Lammert, one of our now neurology fellows, has done characterizing strokes. And that series that she published was actually just in all of the patients that we enrolled here at Hopkins across both arms of the trial, both the agenesis and the fetal renal failure arm. And so, as Stephanie said, it hasn't just been here, but because you know, we did not build into RAFT a mechanism to collect, say, neuroimaging from every patient across the study, because that was not, you know, not something that we were clearly going to need to do. We actually didn't have that built into the study. So the reason that she did a single center publication was because she could get all the neuroimaging easily here, because it turned out to be very difficult to try and retroactively get images from patients at other centers. Okay, so I'm going to talk about approach to renal replacement therapy in infants with CACET and end-stage kidney disease from birth. And I will also be weaving into this a little bit in an ongoing way, some of the ways that we do prenatal counseling. in these families and the things that we try to cover. But I do want to draw your attention to this really great recently available video that is now on YouTube, and I've put the link up there. So this is something that Donna Clace, who was at Cincinnati Children's, but now is division chief out at Children's Mercy, but she put this together. And this is less than 5 minutes long, but it is kind of an educational video about neonatal dialysis modalities aimed at families, and is something that can be really useful to use during the prenatal consult process, because it's something that patients can revisit. So, and it's technically focused on dialysis. It doesn't talk about long-term things or journey to transplant or that kind of thing. But I think this is a really great resource that I'm using now and is publicly available. Donna felt really strongly that that it should be available publicly to everyone. So I would encourage you to take a look at it, and she got lots of input in putting this together, and it's a really great resource. I promise this is the only slide I have on the physiologic principles of dialysis. For those of you where this is not your area, but you know, when we think about dialysis in neonates, the purpose is the same as dialysis in anyone. And there's two sort of things that have to happen. There has to be ultrafiltration, which is removal of fluid, and then clearance, which is removal of solute. And you can do that by hemodialysis, or you can do it by PD. Ultrafiltration, if you're doing hemodialysis, happens with hydrostatic pressure. And then in PD, we do ultrafiltration using osmotic pressure with dextrose in the dialysate. And then there's the clearance part of dialysis, which is the removal of solutes, so potassium, other salts, phosphorus, urea. And that happens a couple of ways. So there's the diffusion component that happens not only in hemodialysis, but in peritoneal dialysis too. And so diffusion, if you remember, is just the transmembrane solute movement in response to a concentration gradient. And dialysis is most effective at doing this for very small solutes. And then there's also convection of solute that happens. And so this is when there's some transmembrane solute movement that's associated with ultrafiltration. When there's ultrafiltered plasma water. And so this is kind of the solute drag. And so in hemodialysis, when we do this with standard hemodialysis machines, you can separate ultrafiltration and clearance. When we're doing PD, we can't really separate them. We do them together, but the clearance happens by concentration gradient, and the ultrafiltration happens via a dextrose gradient in the fluid. I will say, despite what Yair said earlier, I am not actually an expert in neonatal dialysis modalities in any way, any more than any other pediatric nephrologist. I've never developed any dialysis devices, but I can tell you, and I'll tell you a little bit more about what we do here at Hopkins, which is what I know best. And many of you may have experience with the modalities of dialysis that I don't. But our primary modality really, and the modality in most neonates, is peritoneal dialysis. And so this is where a sterile dialysate is introduced directly into the peritoneal cavity, and dialysis happens across that peritoneal membrane, which is the membrane that lines the abdominal cavity and the over the surface of the abdominal organs. And then there are these little capillaries and blood. The dialysis exchange actually happens right across the capillaries that are adjacent to the peritoneal membrane. And so in many people, there's, interval passes, and this is sort of how peritoneal dialysis often starts in the NICU, because when you're doing very small volume passes, that's not feasible on the dialysis cycler that I'll talk more about later. I put up this, and I'm sorry this isn't super clear, but this is sort of a diagram of what the PD catheter tunnel is supposed to do through the abdomen. And so you can see there are many catheters have these two cuffs, although some catheters and some neonatal catheters actually have only one cuff. And the cuffs are there to sort of form a ring of scar tissue that seals off the tunnel and makes it waterproof. And part of what happens to make that possible is the catheter goes into the epidermis and then is tunneled through the subcutaneous tissue. So there's an oblique tunnel between the skin and the rectus muscle before the catheter then enters into the peritoneal space. And then there's these two cuffs that are supposed to be, one is in the abdominal wall, one is in the muscle layer. and they form a nice barrier. You can see in this diagram, this is not a small preterm neonate because there's a fair amount of subcutaneous tissue here. I'm showing you this to talk about some of the challenges in trying to place and heal a peritoneal dialysis catheter, especially in a small preterm neonate, where there really is not tissue for this tunnel, right? There is not a lot of subcutaneous tissue for this tunnel to happen, which is why we'll talk about this more. There can be tunnel healing issues, and why you really need a pediatric surgeon who is adept at and interested in placing neonatal peritoneal dialysis catheters. And we are really lucky to have at least one very good partner in this in pediatric surgery here at Hopkins, who really understands the importance of trying to do this and works with us and has made this sort of an area of expertise. And I know not every single center is lucky enough to have that. But part of what this means is, this is all, I cover this in our prenatal consults too. I tell a family, we get a peritoneal catheter in as soon as we can. And then what that means is the baby is essentially going to be immobilized. So even if they are, not intubated, not ventilated, they're on a non-invasive form of ventilation where they may otherwise be able to be held. We say for healing purposes, once that PD catheter goes in, we want every chance for that to heal and not leak, and for us to be able to start PD in an uninterrupted way. And so that for at least a week and maybe even 2 weeks, the baby is not going to be able to be picked up and held, that we try to have them be as immobilized as possible. And that's really hard for families to hear. And I like to introduce that early because, and it's not because we don't think that's important, and it's not because we, don't want them to have that experience, but because we really need that. We want that catheter to heal because our goal is really PD first and hemodialysis only if we need to. And so here's some pictures of just some different neonatal peritoneal dialysis catheters that are available. So there are straight catheters, there are curved catheters, there are different sized catheters, there are pediatric catheters, there are infant catheters, and then there is a neonatal type of catheter. The difference in size for those is a length. So I think the shortest neonatal catheter is about a 31 centimeter. And so, we have been successful in putting peritoneal dialysis catheters in relatively small babies. But the other thing that I make sure to cover in all of the consults, and this is one of the pieces of bad news I give, is, it is possible for a baby to be born too small to have surgical dialysis access placed. And that is just real. So if a baby is born extremely preterm or low birth weight, sometimes they physically can't get either a peritoneal dialysis or potentially hemodialysis catheter in place. And so that's something I think is important to say to families when they're considering a fetal intervention, so that they know that ahead of time. So I'm sure many of you, anyone who's had a neonate on PD knows some of these complications well, and there are a lot of them. So infection is a huge complication, right? Exit site infections, tunnel infections, peritonitis, all of which can lead to having to shut down peritoneal dialysis or change modalities. But impaired healing and leaking of the PD catheter exit site can be a huge problem that can cause PD to not be possible. This is something when Dr. Riddle mentioned previously that nutrition is really important for healing these catheters. I wholeheartedly agree. But then there are other things that can happen, obstruction of the catheters. And I'll show you some examples of that, or anatomic contraindications. So I think, prenatally, we know what we know, but sometimes postnatally, there are surprises, and infants have intra-abdominal processes that ultimately make PD not feasible. And those are things we have to anticipate. And so another thing I usually try to tell families is the PD catheter, the first PD catheter they get in the NICU is probably not going to be the catheter they go home with. Maybe it will be, and that would be great. But often infants need catheter replacements even during that initial NICU course. I'm showing you a couple of pictures here. So on the right upper photo, this is actually some omentum that is wrapped around a dialysis catheter. And you can see, so the catheters don't have just one opening. I mean, they're fenestrated and they have lots of openings, but this omentum has done a great job of wrapping around every single potential opening in that catheter. And So this is a situation where obviously inflow and outflow are going to be really compromised. Now, often when the surgeons go in and put a PD catheter, they try to do an omentectomy. If there's obvious omentum, they will try to get it. You know, it's the smaller the baby and the less stable the baby, the harder that is, because that also is associated with bleeding. But they try to get it out, but the omentum grows. The omentum grows with the baby. And so sometimes this happens, and sometimes the surgeons can go in and do something laparoscopically and get it off, and sometimes they just can't salvage the catheter. And then the photo below is a fibrin, a big sort of fibrin Goomba that was pulled out of a dialysis catheter. So obviously, anytime there's abdominal surgery, there's going to be fibrin deposition. And so this is something that we sometimes see, and this can be a catheter complication as well. When we try to mitigate this, and I'm sure different centers have different practices, but we really try to, even if we're not doing passes right away, at least do maybe 2 passes a day of a heparin containing dialysate, just to kind of keep things flowing and try to keep a lot of fibrin from building up in the catheter, so that when we are ready to use it with sort of passes appropriate for the infant size, it will still be functioning even if we've let it heal for 1 to 2 weeks. The ultimate goal with PD is to get kids home on the PD cycler. And so initially, passes are very small and are likely manually done. But then this is a picture of the Baxter cycler, which is the cycler that we use both inpatient once infants get big enough to have a pass volume, even a low volume that works with the cycler. And then it's the same machine that's used at home. And so on the right, there's a picture of this is the toddler this was actually a baby enrolled in the RAF trial, who went home on PD. And, part of my prenatal consult is talking about what PD is like at home for families. And I'll say, it's usually somewhere between 10 and 14 hours a night. And it's usually done, during sleep, although that's not always possible. And for this particular, you can see this baby is up. This was a kid who really loved to roll over and obstruct his PD catheter at night. And so, his family tried for months and months on the cycler, but they were up maybe every hour to 2 hours for months on end with the cycler alarming. And finally, they decided that it was better for everyone to sleep at night, and they would just do his PD during the day. And that meant basically they couldn't leave the house because the baby is attached to the cycler during the day, but it worked out much better for them in the long run. And so it's actually now embarrassing how long it took any of us to maybe think of that as an option for them. But just to give you an idea of what this can be like at home, and they're going to be on dialysis for years, as we'll talk about later. And then this is not to really talk to you about the cycler, but just to show you some of the program settings that the families are going to deal with at home once they're actually managing dialysis themselves, and some of the different things that we have to think about when we're programming a cycler. But we don't have time to talk about that. I will talk about, hemodialysis machines. You guys are familiar with a lot of these machines. So we have some intermittent, machines that can be used for intermittent or continuous dialysis. There's the Carpe Diem machine, which many centers use for continuous dialysis in neonates and infants. I'll say at our center, we use the Next Stage almost exclusively, and we've used that in infants as small as 3 kilos. We have had one circumstance where we've had a baby smaller than that who we actually have transferred to another center to get another form of dialysis. And then, this is the Aqueducts machine that you've heard about, and many of you may be familiar with this as well. So it's the Aqueducts Flex Flow system. This is actually not an FDA approved, pediatric dialysis device. It is an isolated ultrafiltration device that's FDA approved to use in adults it was designed for adults with diuretic resistant congestive heart failure so that they could have ultrafiltration using a peripheral IV or even a PICC line. But it is able to be used, to be adjusted and used as a dialysis device for small infants, allowing slow continuous ultrafiltration. Although infants generally still require a central line in order, you could never do this through a peripheral IV in an infant. You need a central line. But there's a publication here from Shaina Menon summarizing a series. It was 117 patients who got Aqueducts. Most of them were less than 10 kilos, mostly for AKI due to underlying kidney disease or cardiac disease, and showed that 60% of those survived to the end of renal replacement therapy or went on to be transitioned to another modality of therapy. So this is another method that is available. We don't use this here either. We did do a trial of it many years ago in our PICU, and due to some of the challenges it's labor intensive. For those of you that have used this in your NICU, it's very labor intensive in terms of the ins and outs. Like in an adult, you can be 10% off in the volume removed, and it doesn't really matter if you're a 250-pound adult, but you have to be a lot more attentive to fluid balance when using the Aqueducts in infants. What I want to talk about, I'll mostly finish and we'll briefly touch on transplant because I know I'm running out of time, but is vascular access in neonates and the approach to this and why we really like to do PD first, if at all possible, in these infants. This is a picture courtesy of Ruxana Shroff, who some of you may know. She's a pediatric nephrologist at Great Ormond Street in London. And this is a picture that she let me borrow, and she always uses this in her dialysis access in infants talk. And this is a 1-year-old who you can see all these accessory vessels on their chest, who's basically stenosed all of their upper vascular access related to multiple hemodialysis catheter placements and replacements. This is a huge issue because having central venous access placed, as an infant and needing repeated placement can lead to damage to the central venous system, and can compromise those central vessels and can, in the future, actually prohibit the use of upper extremities for AV grafts or fistulas, or in the case of putting in femoral access, compromise vessels for future transplant anastomosis. So some of the things we think about in kids with end stage are vein preservation, avoiding central lines if at all possible, and then going distal versus proximal when placing dialysis access. This is and you have to think about this a little bit differently in the infant who's born with what is end-stage kidney disease versus other infants and toddlers that we see in the ICU setting who have AKI and get, emergent hemodialysis as a bridging therapy, but who go on to recover and won't for sure need future dialysis access. Our patients will. They're going to need dialysis throughout their lives, likely multiple courses of dialysis. And so peritoneal dialysis really, should be the gold dialysis modality for infants. And we should do hemodialysis really only when peritoneal dialysis is clinically contraindicated. Now, a clinical contraindication might be that you don't have a person that's willing to try putting a PD catheter in a very small neonate. And that is a clinical limitation at some centers that is very real. But just to keep in mind, patients are going to need to return to dialysis multiple times in their life. And having a peritoneal membrane that fails, because no peritoneal membrane lasts forever, unfortunately. Being exposed to dextrose is scarring, a peritonitis is scarring. So just trying to, we want to get kids on dialysis as soon as possible, but I can tell you, and different centers have different approaches to this, but, we really try to get kids on PD. And we will do the best nutrition we can, but we do have to restrict nutrition while they're healing. But we really feel that it's in the patient's best interest to have as little vascular access early on as they possibly can have. And then I'm just going to finish because I know I'm at time, but kidney transplant, the other thing we talk about with families, the one thing that we have to say, in the lay knowledge is that kidney transplant's a cure for kidney failure. We all know that that's not the case. We know that transplant is just another modality of renal replacement therapy like dialysis. The other thing that families are often surprised by is that you can't do a kidney transplant in a baby. And so we want them to be 10 kilograms and about 2 years of age. That's whether it's a deceased or a living donor. That partly is just we transplant adult-sized kidneys generally into toddlers, and so there needs to be a big enough space in either the abdomen or the iliac fossa, but also that's because of the vascular anastomosis. Like, doing transplants in little tiny babies has a very high risk for thrombosis at the anastomosis. And then obviously, you know, especially in kids with CACET, there has to be a lower urinary tract management plan in place. Even if that's a temporary ureterostomy, that needs to be in place. And sometimes that can delay transplant as well. Transplants don't last forever. We want families, we counsel them that children are going to require repeated transplants if they survive to their first transplant, and that when transplants fail, patients are likely to return to dialysis prior to their subsequent transplants, and that they're going to need lifelong immunosuppressive treatment with all the risks attendant on that. So I think there's a lot more I could say about that, but I am definitely out of time. So in the interest of that, I'm going to stop sharing.
Doctors Riddle and Atkinson, thank you so much. You know, I think to piggyback off of Dr. Riddle's analogy initially of the yellow brick road and getting back to the importance of good prenatal, perinatal counseling, right? That yellow brick road, there is really no Oz. There really is no destination. It's just an ongoing road of potential complications. And I think, Dr. Atkinson, like you said, when I first started my nephrology training, for those who may not be as familiar, a kidney lasts about 10 to 15 years. When a patient is an adult, it is a lot more difficult for them to get a kidney transplant. So I think it's just so important to make sure family knows the road that they're signing up for with this journey. And I think it's a nice segue into our final portion of the talk on the ethical considerations in this patient population.